Thanks everyone for joining in on Zoom and also on YouTube. My name is Salman from McGill. As part of CamSign, we're very excited to have two of the leaders, really stellar neurosurgeons and educators and researchers joining us this evening. Dr. Keeper from Harvard, Dr. Frederick Boop will be joining us for the hour. The purpose of the session is to foster interest in global neurosurgery and the valuable perspectives that the public health plays really in that interplay. So I'm very excited to see Dr. Park and all of you that are interested, and I'll pass it on to Devane to deliver the bios so we can get started.
Well, thank you, Simon, and thank you, Dr. Park, for agreeing to be with us today. So briefly, Dr. Park is a consultant for the World Health Organization, and he serves on the WHO Expert Advisory Panel on Surgical Care and Anesthesia. In this capacity, he advocates for and assists in the development of national surgical plans by the member states. He is also the editor-in-chief of the Journal of Global Neurosurgery. He is the Director of Policy and Advocacy Program in Global Surgery and Social Change. Dr. Park is a consultant for the World Health Organization and serves on the WHO as on panel as on surgical care and anesthesia. Sorry for the repeat. So Dr. Park will be giving a lecture followed by questions and answers at the end. Thank you, Dr. Park, for being with us today. The stage is all yours.
Yeah, can you all hear me okay? Yeah, perfect. Yeah, thanks, Saman and Divine, for inviting me and organizing this talk. I understand that Dr. Rick Boop is following me after this hour. He's another champion for global neurosurgery, and I think my talk, which is really about a higher level global neurosurgery, 30,000-foot view, is complemented really nicely from with Dr. Boop's talk, which is really about advocacy, which is an active component of what neurosurgeons can do. And I was talking to Saman, and CamSign is an interest group for anyone who's really interested in neurosurgery as a field. And it's been my experience that there's always a handful of people, 10 to 20% or so, that have this, sort of a global health perspective. They've had this interest, and you can't remove it from them. It's part of their DNA. But there's still a small percentage who I think maybe they're not sure, and I hope by end of this talk, I can convert some of you to think about global neurosurgery as a viable path within the neurosurgical profession. So, I've named this talk Global Neurosurgery, the Pursuit of Neurosurgical Equity, because people, when you say global neurosurgery, really there's, you ask 10 people, you might get 10 different definitions. And I'll go over the definition towards the end. But the essence of it is equity. It's about fairness, social justice. And we live in high-income countries. I live in the US, you all live in Canada. We enjoy social benefits, right? A good health system, affordable health. Well, I don't know affordable, but in the US, but healthcare when we need it, and wherever, whenever. But that's not the case in really the majority of the world, especially the poorest. And the idea really is that those that have been given much is expected. That's us. It is our job to take care of the ones that are less fortunate. So that's I love the word equity in that title. That's why I put it in there. So let me see here. Here we go. We have some time, so sit back, relax. I'm going to start off with a high-level view of global surgery, right? I don't know if you guys have been keeping up to date, but global health is being the landscape has changed, and surgical care is now really center stage in many ways. I'll try to sort of give you that perspective. Then we'll do a little more deeper dive into global surgery, how it got started, the era of humanitarian neurosurgery, how that's shifted to really a public health approach. Give you some examples. And then I'm going to share with you some observations that I did not expect when I was started this journey. And I think it bodes well for this crowd here, because it's changing, your training, what your training will look like, what your options are. And then, of course, then at the end, advocacy, but Dr. Boop's going to really dive into that topic. So global surgery, how did it start? Well, before I start here, I'll start here. 15 years ago, right? Seems like not that long ago. 15 years ago, Paul Farmer and Jim Kim wrote an article and was published in the World Journal of Surgery, right? They're both infectious diseases doctors, and you probably know that. And they published in a surgical journal with this, pretty much their tagline is, surgery is the neglected stepchild of global health. And I don't know about you all, but when I read this, I said, that's not good. Right? It's almost, I saw it as an indictment of our ignorance and our lack of involvement. I didn't see it as more of what's happening in global health governance. It's really that the surgical profession had neglected to really dive into this space, and that's what a lot of others felt, and that's to me the beginning of sort of the movement to say, let's do something about this. So fast forward 15 years, this is the map of the world, obviously. The countries that are colored in blue are countries that are actively developing policies and implementing policies to strengthen surgical care, especially at the district hospital level. Okay? When we talk about neglected, stepchild global health, we're not talking about, high-tech for-profit healthcare. We're talking really about the public health system. It's a lot of countries. It's about 45, 50 countries. And this is where we are right now in 2023 with so many countries developing national surgical plans, with development finance institutions trying to figure out how to finance these things, ministries of finance, those kinds of things. It's an exciting time in global health. It's been dominated by infectious diseases people, and when I don't know about you, in your clerkships, they're really nice, the infectious disease consultants. They're rarely confrontational, and I'm not trying to say anything negative about them, but they're happy with status quo, or they're too accepting of the status quo. What I've observed when surgeons moved into global health, they're not happy, and they absolutely committed to changes. And I've seen this happen, and it's really exciting because it's changing the dynamics of global health governance overall. Okay, so how did this happen? So 2008, the article published with Paul Farmer and Jim Kim. And then there was a Lancet Commission on Global Surgery that was published in 2015. And that John Mira was the lead on that commission, along with a couple of others, Andy Leather, Lars Agander. And they had a question: what is the scope and the breadth of the problem of unmet surgical needs, specifically in lower middle income countries? And that's the question they try to answer. And I think probably most of you maybe not, but some of you have read the Lancet Commission report. 5 billion people around the world do not have access to safe, affordable, and timely surgical care. It's more than half the world. The number of operations that are currently unmet due to lack of capacity, 143 million operations a year. And 17, 18 million people die every year because of the inability to access surgical care. That's 3 times people that die that die from HIV/AIDS, TB, and malaria. 3 times, right? So it's a huge global health problem, and that's the Lancet Commission. Then at the same time, in 2015, the World Bank and Gates Foundation funded a disease control priorities. They've been doing this for quite some time. This is the 3rd edition. And this particular edition of Disease Control Priorities, the first volume was entirely devoted to essential surgical care. And that created sort of a groundswell within global health, surgical advocates coming forth and really trying to get, how do we get global health governance to really pay attention to this? It took the form of a World Health Assembly resolution. This is where in Geneva, 194 member states, health ministries around the world come together and set priorities. And there was a resolution introduced by Zambia, co-sponsored by US, It calls for strengthening emergency and essential surgical care and anesthesia as a component of UHC. Why was UHC in there? Because in 2015, also the Sustainable Development Goals were launched, and one of the targets within this goal, the number 3 is health, and one of the health goals was UHC, universal health coverage. This resolution passed unanimously, and to this date, this is the resolution that sort of gave marching orders for health ministries and WHO and anyone that's working in global surgery, at least in the policy space, to go back to this resolution and saying, hey, we're just implementing the recommendations from this resolution. So so can we backtrack a little bit, take a little pause, because I think Saman asked me how I got into this thing. I was a private practice neurosurgeon in the US for 12 years. Loved it. What's not to like, right? But after about 12 years, it occurred to me that I had more than enough. And I was a lucky guy. And I felt like there was a reason why I was so blessed with so many things. And then, I felt like I had an obligation to give back. And then it took, I went overseas. I went to Ethiopia, then Cambodia, and I started teaching neurosurgeons in those countries. And then in 2015, I read the Lancet Commission on Global Surgery. By this point, it was clear to me that training additional surgeons was an essential component, but certainly insufficient to make sustainable changes. I knew it was going to have to be a public health approach. I came back, did a fellowship with Dr. Mira, who was the Lancet Commissioner for Global Surgery. I did a master's in public health because my skills in the operating room and in the wards had zero impact when I'm talking to public health officials. They speak in a different language. So I got a master's in public health, and I finished that. And I was invited to stay on as faculty at the program in global surgery and social change. So in a nutshell, that's my brief journey, how I got here. A quick, yeah, that's good. So now within the program in global surgery and social change, we don't actually go and deliver surgical care or provide equipment or anything like that. We don't do what I consider surgical work, service work. There are plenty of NGOs and academic institutions that do that, and they do it very well. We specifically focus on a policy dialogue with health ministries. And we came up with a framework for scaling up surgical care using the WHO's health system building blocks framework, and developed a manual to help health ministries to think about doing a gap analysis, a priority setting, and then developing a national surgical plan. It's a process to do that. And we did that in conjunction with WHO. And then we started to give workshops to health ministries around the world. Now, this is why that map with the blue countries, all those countries are working on national surgical plans. I do have to give a shout out to a gentleman here on the right. There's a, let me see if you can see him right here to the right, standing there. His name is Dr. Walter Johnson. He was the first person that was hired by WHO headquarters in Geneva to implement the Resolution 6815. Dr. Johnson happens to be a neurosurgeon. And I have to tell you, the fact that he was a neurosurgeon sitting in Geneva in 2015 had everything to do with the fact that global neurosurgery is where it's at today. And it's almost taking a leadership position compared to other subspecialties within global surgery movement. So this are some examples of national surgical plans that our program in global surgery and social change have been working with health ministries to develop these plans. This one's from Tanzania. The middle picture is actually the manual now. We've codified it. We created a book, and then now it's downloadable from UNITAR, UN Institute for Training and Research. There's a guy, I don't know this. There's a picture on the right upper side with me on the other side of it. That's Dr. Alfredo Borrero. He's the vice president of Ecuador. And he approached Dr. Mira, my boss, and said, we want PGSSC to help Ecuador improve our surgical systems. And Dr. Mira couldn't go, and there was a meeting in Berlin, so I went and as an alternate. Just so happens, Dr. Borrero is a neurosurgeon. And you see there's a theme here, guys, right? And gals. We hit it off right away. We had mutual friends, and we said, yes, we will help Ecuador with scaling up surgical care. And Dr. Barrero just visited Harvard like last week. And we have a team Ecuador working with them, and it's coming together very nicely. But in turn, I turned the tables and said to Dr. Barrero, listen, we need help from people like you for the global surgery movement. Would you help champion surgical care within global health? He was like, absolutely. So he's been championing surgical care within the Latin America and the Caribbean's PAHO, Pan American Health Organization, which is a WHO regional office. He just met with the regional director to try to put surgical care at the top of the list. And he's also been a champion for surgical care, not just neurosurgical, surgical care at the WHO. He comes to the World Health Assembly and talks to Director General Tedros and says, what are you going to do? Keeps him accountable. But when you have someone like his number 2 head of state, that's pretty powerful. Then Key Park coming in, and say, hey, when are you going to get these countries to respond and keep them accountable? So yeah, that's Vice President Barrero. Is a fantastic ally to the global surgery and global neurosurgery movement. I think I mentioned earlier, then, we have these countries developing national surgical plans. The poorest of the poor countries cannot implement these plans without really external assistance. We know that. Middle income countries, they might be able to increase their taxes, other things. But we do know that there's a space, there's a role for external assistance in health. And when we went to USAID initially and said, hey, there's a huge unmet need, these countries are working on it, and USAID should help with, these surgical systems, we were like shut out. They were like saying, here's what we're supposed to do by US Congress. US Congress holds the purse strings, and they control the budget for all foreign ops. And they said, surgery's not on the list. Sorry. So that started, and I think hopefully Dr. Boop will get into the advocacy aspects of it, because neurosurgeons came together with all the other surgical subspecialties in the US with American College of Surgeons, and we're successful in advocating to our members of Congress to insert the language, and it shows now it's in there. USAID shall support strengthening surgical systems, right? Systems level, not just mission work, and assist health ministries in developing national surgical plans. It's in there. It just so happens the current assistant administrator in charge of global health at USAID is a surgeon, not a neurosurgeon. I think he wanted to be a neurosurgeon, but he couldn't be. So he's an endocrine surgeon. His name is Dr. Atul Gawande. Okay. But he was one of the people that was part of the global surgery community working on a Lancet Commission early on. So he's definitely an insider, and it definitely helps to have him at that role. Okay, switching gears, we're gonna go to global neurosurgery now, okay? And I put this slide here, it's FEANS. I don't know if you, maybe many of you may not know it. It stands for Foundation for International Education in Neurological Surgery. And I want to, at this point, give a shout out to Moji Hodai. I think she's an advisor to CAMSIGN, and she's a dear friend of mine. And she was a FEANS volunteer and was actively involved with this. And that goes to sort of talking about humanitarian surgery, which was what we all did. I did this. I was a FEANS volunteer. That's how I ended up in Ethiopia, and then ultimately in Cambodia. So it started off as an idea to help from high-income countries to low-income countries as a sort of a charity model, right? We need to do something with it. And there's nothing bad about it, folks. We should always be charitable and kind. However, the problem that we're trying to attack cannot be solved through charity alone. That's the problem. But that's how global neurosurgery started, in many ways, global surgery. I just wanted to give shout out to FEANS. So as I mentioned, there's been that, what's been shifting now over the last decade or so is this idea that training and missions is great. We should continue that. But can we align that to a more of a strategic way of assisting health ministries, working with local neurosurgeons, neurosurgical associations, right? Not a one-on-one. What do you need? Oh yeah, we'll bring that up. Yeah. Let's talk about a bigger picture so that we have some targets that we can hit. And we want to have an outcome, which is really a strengthened neurosurgical system as part of a strengthened surgical system. That's what we're looking to do. And we do it in a spirit of solidarity, not like, oh, we're going to help you, but no, we're all in this together, and we're all in a partnership. And it's the idea is countries are leading these processes, and we're there to support them. So what did that look like? So I mentioned Walter Johnson was in Geneva. He was hired in 2015. I met him, and at the end of 2015, 2016 now, he gave us he brought a number of stakeholders to Geneva, and he included a handful of neurosurgeons, and said, "Hey, you guys should map out a plan to bring neurosurgical care within this global surgery movement." And so it was me, Andreas Rubiano, Gail Rousseau, a couple of others I can't recall right now, and we said, you know what? We don't really have a unified thinking behind addressing this unmet neurosurgical needs around the world. It's still really fragmented. We do donations, this and that. All right, why don't we start off with some sort of a public-facing declaration? And that was the Bogota Declaration at the end of December of 2016. Andreas Rubiano was hosting the neurotrauma meeting in Bogota, and at the end of 2016, he said, "Why don't we do it there?" And we brought in the president of the World Federation of Neurosurgical Societies. That was Franco Servidai at the time. Walter Johnson, you'll see him. He's right next to me on the right side, second from the right. He's also a neurosurgeon. And we handed him this, declaration as a sort of symbolic thing, a commitment. And it was a rallying cry, right? We say there is a massive unmet need for neurosurgical care. Just because, where does our responsibility start and stop? Is it only when they get to the ER and the, ER doc or the resident calls us, "Hey, we have a patient with a hemorrhage, cerebellar hemorrhage." This is how we used to think. What about the ones that couldn't get to the hospital, right? Whose responsibility is that? And what we said was, it's our responsibility. Neurosurgeons, they're our patients too, even though they haven't made it to the hospital. So we call on neurosurgeons and all the professional societies, right? To take urgent coordinated action to lead and address the unmet global neurosurgical need. That was in 2016. It just so happened that the World Congress of Neurosurgery was in Bogota last March. And we got front and center attention at the World Congress. Global neurosurgery is no longer this sort of a miscellaneous. I tell you, we would argue with the organizers of these international congresses saying, this is an important issue. Great. They would bundle us in the program within the miscellaneous, resident training, socioeconomic, ethics, and then global neurosurgery, right? And we kept, and then this is once again, the advocacy is so important to say, no, this needs to be just as important, if anything, as any other major themes within neurosurgery, like vascular, like spine, global neurosurgery. And sure enough, and then you see the gentleman who called into the World Congress is Vice President Alfredo Borrero. He's also lending his voice to this unmet neurosurgical need, the global neurosurgery movement, and he called in from Ecuador at the World Congress. So here we go. What is global neurosurgery? And here's the definition that we've wordsmithed and agreed upon as sort of the current definition of global neurosurgery. And I like it. The clinical and public health. So we're adding on to our sort of responsibilities another dimension of practice, the public health practice, but it has a specific intention. The purpose is to ensure timely, safe, and affordable neurosurgical care to all who need it. That could probably be condensed into neurosurgical equity, right? So that's really the essence of, and the definition that this has been approved by the World Federation of Neurosurgical Societies. And I like it. It might get tweaked in the future some more, but for the time being, it works. So one of the things that the World Federation of Neurosurgical Society did, this is Dr. Franco Servidai. He was the former president, as I mentioned. He said, we need to have a committee for global neurosurgery. That wasn't easy. People say, why do we need a committee? But he said, and he's a neurotrauma specialist, so he saw immediately why we needed to do that. So he developed a committee. he asked me and Abdusamad Alouabi from Morocco to co-chair this committee. And we had a committee of 30 people. This was 2019. And we developed a global neurosurgery action plan. It had 5 parts to it. First is they all start with letter A. That's a trick that, if you guys want to ever change anything and you want people to remember, alliteration is very helpful. Amplify access, align all global neurosurgical activity, right? There are these uncoordinated activity. Advancing relevant research. And this is one of the most exciting parts, I think, is research in global neurosurgery. And then assimilating neurosurgical capacity building within the umbrella of global surgery, right? Which was a natural fit, but we wanted to make it part of our strategic plan. And then 5th part is advocating, right? Neurosurgeons, we hit above our weight. We are well respected among our profession, but not just within our profession of physicians, but even non-physicians, right? The general population think of neurosurgeons as natural leaders, and we're respected. We should use that for public good. So what does that look like? So amplify access. One of the targets was let's measure, let's count the number of neurosurgeons that we have around the world, and keep track of it, right? That's one way, to keep an idea. What is a neurosurgical workforce and where is it going? And it gives each country sort of where they're at. And there's a sort of a, wow, we're really low. We need to do something about that. There's sort of a friendly competition. But this is part of the WFNS website. And this has now been, we just finished another iteration, and then we'll now start looking at trends, whether or not the numbers are going up the way we want. If not, why not? Which countries are going down, those kinds of things. So I think there's a mantra that says, what we don't measure, we can't manage. And so we started measuring workforce. This has been emulated now by the other subspecialties. Plastic surgeons are trying to do the same thing. ENT surgeons are trying to do the same thing. But we're the first subspecialty, just so you guys know. And then we followed the Lancet Commission on Global Surgery's playbook. Let's put a spotlight on what is the current unmet need. And that was one of the first research projects I undertook when I got to the program in global surgery. We started a global neurosurgery team. Michael Dewan, who's now a pediatric, he was a fellow, our first ever fellow. He's now at Vanderbilt, and he started his own global neurosurgery center, a program within Vanderbilt Neurosurgery. But he led this, the estimation, the global unmet need, 5 million unmet neurosurgical operations around the world. And this was not just a back of the napkin exercise. We had 10 systematic reviews that fed into this, meta-analysis. And then since we had done the counting of neurosurgeons, we were also able to calculate how many additional neurosurgeons were needed. 23,000 is the current gap, and we need it today, right? That's we need that workforce scaled up as soon as possible. Now, that I work within the program in global surgery and social change with national surgical plan development. We provide technical assistance to health ministries. As a neurosurgeon, I saw how these plans came together. And if we wanted to make sure that neurosurgical care was embedded within the national surgical plans, we need to have a plan. And the plan was to put to convince ministries of health to prioritize head and spine injuries. Why is that? A couple of reasons. If you look at the number one reason why people die in lower middle income countries from trauma, road traffic accidents is number one mechanism. It's head injuries, number one. Number two, there's a UN target to reduce road traffic injuries and death by 50% by 2020, but now that's been extended. And then if you look at our data, the neurosurgery data, that 5 million unmet neurosurgical needs, more than half of that are head injuries. So we said, let's focus on head injuries and then try to provide recommendations that could be overlaid on top of the National Surgical Planning template. So that's the basis behind this particular document. I work with Dr. Tariq Khan from Peshawar, Pakistan, and this has been published now. And we use the health systems building blocks framework, which is the same framework that the national surgical plans use. And so our this entire document is designed to be just overlaid right on top. And we've been going to health ministries and saying, please insert these parts into your national surgical plans. Well, what does that look like? For instance, surgical systems, these are not clinical guidelines. It's not like, when do you actually, what's the PCO2 we're aiming for? Those are clinical guidelines. These are recommendations for health systems, workforce, infrastructure, service delivery. So we said, hey, our research shows that the number of neurotrauma centers should be placed no more than 4 hours, right? Which is different than high-income countries. We have that one hour, golden hour, right? That may not be necessarily the case in lower middle income countries. There may be as much as 4 hours. And there's a reason, I don't have time to get into it, but one of the main reasons that that's the case is that probably the most severe cases just don't make it to the hospital anyway. That's just the reality in these developing world. How many neurosurgeons should the health ministry try to train? And so at least to meet the neurotrauma needs, at least one per every 200,000 people. So that gives health ministries some idea of where what their target should be to improve neurotrauma care as part of their national surgical plan. So yeah, I just gave you that one. All right, we're gonna shift gears a little bit to now research. This is outdated. This is 2018, and now it's 2023. My apologies, but the graph looks exactly the same, right? So there's been research and manuscripts that have been beautiful manuscripts talking about neurosurgical care and the lower middle income countries. But once we gave them a mesh term, global neurosurgery, boom, everybody started using that term. So now if you can just search the global neurosurgery as a mesh term, and it's exploding. And in 2016 is when we published, me and Walter Johnson and Bob Dempsey. Bob Dempsey is the chair of the FEANS, and Walter Johnson is a gentleman at WHO. He's no longer there, but that's who was started, who was there. It's just taken off. And I have another slide that just blew me away just recently. Okay, remember I told you the 5 million unmet neurosurgical operations? There was 10 buckets, right, of systematic reviews. This particular one had to do with TBI, right? So this was was one of 10 reviews estimating the global incidence of traumatic brain injury. We published it in Journal of Neurosurgery, and when I went there recently to look at it, there's this little thing called altmetrics. Are you guys familiar with it? Okay, so I see some nodding heads. I don't know what that is. Okay, so I started clicking and doing going down the rabbit hole, and I was just blown away. So 369, I don't know what that is, but then there's a couple of things that I want to point out. This particular manuscript has been full text views has been almost 60,000 times. So this was a behind the paywall, guys. We did not have open access to open access. So there's some obviously subscriptions, but I don't think there's 60,000 subscriptions. I think Journal of Neurosurgery made a killing on this article, guys. And I think I should have told Jim Rucka we wanted to cover more, more forcefully. But so it's 60, and then it's still being there's within the last 30 days. 1,600 times the abstract is viewed. That's just in 1 month, and it keeps going. So for the year that this paper was published was 2018. It's, of all the Journal of Neurosurgery outputs, that's 101 outputs, it's number 1 in terms of altmetrics. Then here's another number, output from the other neurosurgery of all times. So from Journal of Neurosurgery, of all the articles, I think it's over 6,000 articles that they've been tracking. It's number 14. And I just checked again today. It's now moved up to number 13. And it's only been around, 4 or 5 years, guys. I guess the point I'm trying to make is that I think there's a viable path for all of you to consider global neurosurgery as a research and grants. You will have significant impact. People are interested in this topic. And this took me completely by surprise. We did not do this to sort of, overshadow the Hunt and Hess grade paper, but I don't know. I think it might happen, guys. Okay, exciting time. Now, the other thing that we did was we got some money together, and this was Andreas Rubiano's initiative. He said, Key, he's the neurotrauma guy from Colombia. There's a system in place, which scientific publication system. It's a cartel, right? It's for-profit industry, and it is directly and it is the antithesis of what we're trying to do in global neurosurgery, global surgery. There's a paywall, there's a to access, but there's actually a cost to publishing, where they didn't do any of the research, but they want to charge us to publish it. And as I mentioned, and I have nothing against journal neurosurgery. Jim Ruck has been nothing but gracious, and he's been supportive of this journal, by the way. You should know that. And so we went ahead and created this journal. It's still not PubMed listed, but it will be eventually. And we give preference to authorship from LMICs, number one, right? We want to. It's all about equity, and no paywall, obviously, no APC. So if you want to submit papers, Journal of Neurosurgery, please, love to see your submissions. Okay, and then we're coming to the end here, but this is the within global surgery, you have policy, research, but you really have to have advocacy, like with USAID and health ministries, at the global health. You'll hear from Dr. Boop at the level of the WHO. There's a World Health Assembly coming up in May. There's some really exciting things happening there, which I think no one expected this, but neurosurgeons are literally driving changes at the global level, at the policy level, through advocacy. Probably the most significant, and I think the only one that only advocacy organization that exists for surgical care, right? There's none for neurosurgery as far as I know, but surgical care is the G4 Alliance. So it is for surgical obstetric trauma and anesthesia care. And as you can see, there's about 80 organizations, institutions, academic societies. They all come together because they have a shared interest in seeing strengthen surgical systems, especially lower middle income countries. Just so happens that Gail Rousseau is now the chair of the board of G4 Alliance. And if you don't know Gail, she's also a neurosurgeon, right? And then we have, I represent the program in global surgery from Harvard as a representative at G4. This is Jesus de Fuentes. He's the next World Congress after Cape Town. The Madrid is going to host the World Congress. He's the World. So he represents WFNS at G4. So even at the advocacy level, we have leadership positions, but sheer number-wise, fair number of neurosurgeons. Tariq Khan is also a member. Richard Moser is a member. So we're a force to be reckoned with, and if that's a good thing, that's a good thing, And then we could do more, but this is just the one slide, and then I'm going to leave it up to Dr. Boop to go into more. So here's the take-home message from me to you. Our profession, I think, historically has enjoyed what I would consider like, wow, neurosurgeons are like Top Gun. In fact, when you go to like the national meetings, they have the Top Gun competition and things like that, right? We celebrate our technical excellence, and we should, because it's probably, that's why I went into neurosurgery, because I love that stuff, right? In fact, there's like at AANS, I'm going there to LA later this week. They have like a recognition for technical excellence, because that's what this is embedded in our DNA, I think, right? So we are known for our operative masters. We should maintain that reputation, right? Of being the Top Gun people within surgical care. We are respected for being maestros within the in the OR. We're also respected for our innovations and our scientists, right? Brain immunotherapy for brain tumors. I mean, there's some really exciting things happening, and neurosurgeons are not only technical experts, but they really are like world-class scientists, really driving, the frontier of medical knowledge. But what we haven't really done in the past is be recognized for our leadership and our as global guardians of global public health, right? I think that's changing. And this is where global neurosurgery comes in. We're not doing this as sort of a side interest of our profession. My hope, and I think this is happening, is to make this into part of our persona, part of our overall, say, of course we're interested in those unmet neurosurgical needs. And here's what we've been doing about it. And we want to set an example to the other specialties. And we want to be the leaders and do it in an excellent way that, that we haven't done in the past. And that's the most exciting change that I've seen happening in our profession. And I think that's my last slide. Let me see. Yes, it is. So now we can have a little conversation. We've got 15 minutes, right? Okay.
Thank you so much, Dr. Park. It was very informative, very inspiring, and just wonderful presentation. So I just asked the audience members to raise their hands. I see Mohammed already has his hand up, so please go ahead.
Yeah, thank you so much, Dr. Park, for a very eye-opening lecture. That was very interesting. Thank you so much. I have a question. Actually, recently, myself, Dr. Mofateh, Saman, and Dr. Bernstein, we were involved in a research. We look at the airway craniotomy in Africa. Maybe you've seen that study before. So we found that actually we tried to find what's the biggest obstacle, in Africa regarding expansion of this method. And we had around 15 local neurosurgeons in African countries that I think all of them mentioned that lack of trained staff is one of the biggest issues, one of the biggest obstacles for expanding these techniques. So my question is that to attack this obstacle, what's the best approach? Do you think it's better to train the staff in the site in those low resource countries, or have them in the more advanced countries such as North America, Europe, and train them there? Which is the maybe the more efficient way to train the staff in order to compensate the unmet needs in those low resource countries?
Great question, Mohammed. I've seen that paper, by the way. I think I tweeted it out or retweeted it. And then Mark Bernstein is a legend, And I mentioned Moji before. There's Rick. Hey, Rick, how you doing? We're just doing Q&A. I set the stage for you, buddy. It's all about having.
They'll give you all the hard questions, so I can follow.
Okay. Oh no. So the question that Mohammed raised was really important. What's better, to bring workforce, I guess in this case neurosurgeons, from LMIC settings to Montreal, to Toronto, to Memphis, to Boston, and give them some training and then send them back? Or is it better to have them work in their sort of native setting and then bring experts in to support them? It's number two, hands down. And I don't know why we still do number one, because it's observerships in the US. They can't even see the patients. I mean, they see the patient, but they can't even touch the patients. It's almost there's some advocacy effort that's going on. Maybe Rick knows about it as well, to try to give them trainee licenses now. But the cost aspect as well. So if you're looking at, let's look at the rate of increase of workforce. You're so much better off. You can train 10 by sending one person over there, right, at the same time. Whereas you can only train one at a time when you bring them here. So yes, there's a role for sort of specialist training, and then bringing people to these fellowships to upskill them. Yeah, there's no question. But from a global neurosurgery perspective, it's really better to train them in their own setting. Yeah.
Thank you so much. Thank you.
Rick, what do you think? You're here. You heard the question.
No, I think there are a lot of good arguments for people training in their own setting, and I think it's important that they have good mentorship. I think it's fine for them to come visit places that are higher income countries, but to train in neurosurgery in the United States, it's 7 years. And if somebody moves their family here and they train for 7 years, they don't want to go back home afterwards. And so it defeats the purpose of trying to increase capacity where it's more needed.
Great point.
Yeah, thank you so much.
I have a quick question. Sorry if there's any background noise. Maybe both for Dr. Boop and Dr. Park. How many people would you estimate you would have not have met if you didn't pursue this sort of global approach of colleagues in different continents, in different countries, different cultures? How would you estimate that? Like
I'll
loss
never
of
met Brooke Boop.
social capital, so to speak.
He's the chair of the department. He's got no business meeting a guy like me.
Yeah, I'm not chair anymore, but yeah. To be honest, you're hearing about global at a time where it's really come into his own. I think he mentioned it earlier. There was a survey a couple of years ago of medical students in North America, and 60% of them said they wanted more medical school education on global healthcare. A similar survey from Europe, over 90% of the medical students wanted more education on what's going on around the world. And I'll frame that in just a few minutes in my talk. But for me, I've learned a lot from him just in my short time in involvement with global neurosurgery. So
Thank you, Rick.
I always learn from you.
I might add this to Rick's comment, which is, we talked about the neurosurgeons being more of like an individual sport type of mentality. You're only going to have the best in like one department and one operation, right? You can't have a team, like a massive team. So that necessarily ends up narrowing, what you can do. In global neurosurgery, there's no way that an individual could make the difference. It has to be collaborative. And so you're forced, whether you like it or not, to have to work with nurses. Not that I'm not saying that in a bad way, because we have some of the best nurses that we work with now in global neurosurgery, and they're just out of this world. But you just have to be able to, bring everybody together under the umbrella and go together. And that's not because it's a nice thing to collaborate, because we won't get those results unless we collaborate. It's a necessity.
Yep.
Excellent. Thank you.
There's a chat. Says Richard Ruan has
go ahead.
Yeah. I'm reading it. Go ahead, Richard. Mohammed, did you have a question, or did you not put your hand down?
Yes. No, I have another question if you don't mind. Yeah.
Wait, yeah, because he's still typing, I think. Go
Yeah,
ahead.
maybe I can ask my question. So my question is that as someone mentioned, I'm starting my residency soon in July. So I'm wondering what's the opportunity for the junior residents like myself, or even like interested medical students, to get involved in global neurosurgery. What role we can play in this like a field?
Well, I'll start, and then maybe I think Dr. Boop has additional comments you could make. Couple of things. First of all, within the department, which one are you going to? Toronto?
No, I'm going to Ottawa.
Ottawa, yeah.
Yeah.
So you have, it all depends on the program, right? So if you go to Toronto, you've got Mark Bernstein and Muji Hodai. I don't know about Ottawa so much, but that's not to say that once you get there, you might find a faculty member who's very much interested in this topic, and you can start something in that way. But then there's extracurricular activities. So the program in global surgery and social change, we have a fellowship program for med students, by the way. That's a research collaborator. People usually do it between third and fourth year of med school in the US, but people who have not entered into training. And for those who are in training, we have a program called Research Fellows, 1 to 2 years. So that's, and then I think there's a number of others that are now offering at least global surgery fellowships. And if you do a fellowship, I would recommend getting a global surgery fellowship, not global neurosurgery fellowship, because you really have to understand the big picture. Yeah, at least from the Canadian point of view, those are the two. There's a few now for people coming from lower middle income countries for some opportunities, but I don't think that's what you're getting at, right? You're really talking about your experience.
So do you recommend to go for like a maybe elective, you know, in the low resources countries as a resident? And if you recommend, if you do so, whether it's better to do it in the junior residency or like in the senior residency?
So I think it's always helpful to understand the context of global neurosurgery. So it's always, you know, to be able to witness and you know, yeah. So if you're able to travel, if you've always been in Canada and always, you know, with Canadian med school, Canadian residency, and you've never set a foot in an OR in Addis Ababa, you know, you may be a very eye-opening experience for you. It was for me.
Thank you so much, Dr. Park.
I think Richard's question is in the chat. Dr. Park, would you like me to read it out loud, or
Oh, I can see it.
the people
Here.
in the
The
recording
biggest-
can also, or you can read it. So, okay, perfect.
Oh, wow, that's a great question. So technology, so I'll briefly talk about it. We still have a few minutes before turning it over to Dr. Boop. I'm really bullish on what's happening in digital technology since the pandemic, right? There's been an increase, like exponential increase in a couple of things. One is digital like ways to communicate in real time. So now there are ways for someone to be virtually present during an operation thousands of miles away, right? So that opens up a whole new way of coaching. I don't think you can do surgery. People say, "Oh, you can do Zoom surgery." No, you can't operate out through a, you know, a digital pathway, but you can definitely coach. You know, show where the incision is. Don't touch that. Let's, you know, push this away. That kind of stuff. And the bandwidth, you know, the internet connectivity issues have gotten much better. The technology, like Proximity, is one company that comes to mind that's able to do that. But they're not the only game in town. There's a number of other companies. But using virtual, you know, glasses and sort of virtual participation. There's also you know, the augmented reality to sort of look at the images and superimpose it on surgical, you know, cadavers or even patients, and that can really help training in LMIC setting. And then there's also the whole idea of, so that could accelerate the training process, and then at the same time also help with the delivery of care as well, right? You know, telemedicine is like now a standard thing here in the US. And then I'm just scratching the surface, guys. This is a whole AI thing. You know, do we really need radiologists in LMIC setting? So yeah, there's a lot that's happening. Is that Richard? Yeah, Richard. Yeah, so there's a bunch of articles I've been seeing and looking at technology and neurosurgery, and we're actually in the process of looking at the technology, the current the evolution and technology, and looking at through global neurosurgery, right? So LMIC setting, capacity building, those kind of things. Stay tuned.
Dr. Park?
Devane,
Yeah.
go ahead, please.
I had a quick question for myself. Thank you for your very inspirational and eye-opening talk. I really appreciated it. You mentioned previously about a fellowship research collaborative for medical students. For students that are not in the US, are the USMLE licensing exams required for us to be able to follow the program?
No, these are not clinical fellowships. These are non-clinical. And we have fellows from Malaysia. We have fellows from Nigeria, students from all over the world. Yeah.
Good. Thank you.
I just put
Sorry, I have one more question. I'm not sure if there's anyone.
Go ahead.
Sorry, I do have a bit of a maybe 2-3 second delay. So if I'm speaking, you hear it later, I apologize. Maybe if you were to give us, some of us are medical students, some of us are going to be becoming residents, what would be one word of advice you would give so that we go into our training with that perspective for both Dr. Boop and Dr. Park? What would you say?
Can you rephrase that question? I think I understand it, but
Sure. Right. So in terms of, because the insight that you've gained through these initiatives and all the work that you're doing really is upstream change in developing countries and, mandating options, resources, managing all of that. What sort of things should a medical student and a resident be mindful of, in addition to the technical prowess of their surgical skills and the knowledge of anatomy and other things, that they should have competency in, should they be wanting to pursue global neurosurgery down the line, or global surgery for that matter? What would you respond to that?
So I do have a comment about that, Saman. It's a great question, and it's not a technical answer. It is not about, knowledge about caring for patients or even health systems knowledge. It's about being aware of our privilege. From people who are coming from a high-income country, and privilege is something that we did not earn. But people think that, and then there's that dynamic, and it's all about, for me at least, seeing them as equal and never as less than, right? And the reason I'm there is not because I'm better or smarter or wealthier. It's because I've been given a lot more than I deserve. So the understanding my positionality is I think that's that for me is very important.
I like the way you frame that, Key. I think that's terribly important, and it's something that it's hard to keep in perspective when you start into training, that we're all created equal, and just because you're a brain surgeon doesn't mean that you're the cream of the cream. You're the same as everyone around you. I will say that the world has gotten very small, and there are a number of international neurosurgical groups nowadays that, for example, I do pediatric neurosurgery. Our ISBN now has a medical student membership category. So you can join even before you get into your neurosurgery training. And as a candidate member, while you're going through training, there's no membership fee, but you get access to the journal. There are international societies for spine, for trauma. The WFNS is all of neurosurgery, and they have committees that medical students can serve on or be a part of. So when you start into training in your first 2 years, you're so inundated with just learning the basics of neurosurgery, you don't really have a lot of time for that. But there are plenty of opportunities as you get time. And I can tell you virtual lectures like this have changed the world in terms of what your opportunities are. I can tell you my son is a neurosurgery resident, and when I say, well, what do you study when you're getting ready to do a case the next day? He says, we don't buy textbooks anymore, Dad. We look at the Neurosurgical Atlas. We look at the Roten collection. We can go to Neurosurgical Focus and see people do the surgery that we're going to do tomorrow in edited videos. So when I see residents sitting in the surgery lounge, they're looking at the surgery they're getting ready to go do, which is an opportunity that my generation never had. So you guys are really fortunate. You're coming to neurosurgery at a wonderful time.
Thank you very much for those very enlightening responses. I think it's 6 o'clock, but I don't want to keep Dr. Park longer in. But if anyone has like a really burning question within 30 seconds that we could entertain, and if not, I don't see any, I'll pass it on to my colleague Devine to introduce Dr. Poop. And again, thank you so much, Dr. Park, for joining us today.
Saman.
It really is an honor.
And Rick, I'm sorry, but I gotta sign off because I'm on spring break for my daughter. I'm sure it's gonna be a great talk, though. I'll see you soon.
Are you guys skiing or what?
Yeah, we're in Park City. Yeah,
I thought you would be. All right. Enjoy.
you will enjoy Dr. Boop's talk. He's excellent. Bye, everybody. Thank you.
Thank you. Thank you, Dr. Boop, for joining us. So Dr. Boop is the president of the 48th annual meeting of the International Society for Pediatric Neurosurgery, and he is the past president of the American Association of Neurological Surgeons. He has served Sims Murphy Clinic as a member of the board of directors, as chief of Pediatric Neurosurgery Division, and as Pediatric Neurosurgery Fellowship Director. He has held the G.T. Robertson Endowed Chair from the University of Tennessee Health Science Center's Department of Neurosurgery Training Program and St. Jude Endowed Chair in Pediatric Neurosurgery, where he is currently a member of the St. Jude Global Program. He is currently Emeritus Chair at the University of Tennessee. Thank you, Dr. Boo, for being with us. The stage is all yours.
Thank you, Devane. That was nice. So let me share my screen and see if we can bring these slides up. So for the last almost 2 years now, I've been working in the St. Jude Global Program and trying to increase capacity for children with cancer. So there are going to be areas where my talk will overlap with Key Park's, but I'm going to talk about some different things as well. And I want to start out by just framing this picture that you're looking up of our world with where you are in this world, because the world is changing quickly and your position in it is changing too. So I don't have any relevant disclosures here. This next video, I think, shows how small our world has become and how interconnected. And I'm not going to show the whole video, but this is put together by the National Air Traffic Safety Board. And these are flights in and out of Gatwick and Heathrow in a given day. And you can see up here the hours. So this is not including Paris or Frankfurt or Amsterdam, any of the other big airports. This is just Gatwick and Heathrow. And you can see how interconnected our world has become. I mean, you guys can get on a jet today and tomorrow morning you'll be on the other side of the world. So I'll stop that there. And the other thing I want to point out is that our world is changing at a rapid pace. So historically, things changed fairly glacially. Population growth took decades to see a difference. Climate change took decades to see a difference. Big government expenditures were glacial, but you can see that our changes are logarithmic now. And this is a nice book that Tom Friedman put together that talks about how quickly things are changing. But keep in mind, 2007 was when Steve Jobs introduced the first iPhone. And at that time, we didn't have apps. Our whole world has changed just in that short period of time. And what you're learning in neurosurgery is changing that quickly too. So to put the world into perspective, we just in the last few months had our 8 billionth child born into our world. And we currently have 4 births per second for 2 deaths per second. So the world is growing at a very steep pace along with the graph you saw. Worldwide, we have about 140 million births per year, 140 million. And whereas childhood mortality was significant a couple of decades ago, in the last 20 years, the death for children age 5 and under has decreased from 12.5 million to 5 million deaths. So a 60% decrease in childhood mortality just in the last 20 years. So in terms of pediatric neurosurgery, if I tell you there are around 3,000 pediatric neurosurgery surgeons in the world, that means we get 46,000 new children to take care of each year. And in the northern hemispheres, where there's a lot of population control, growth is relatively flat. But in the southern hemispheres, growth is quite steep. And in many countries in the developing world, 45 to 50% of their population is age 18 and under. So if you think that between 4 years of medical school, 7 years of neurosurgery residency, another year sometimes 2 years to do fellowship, it takes easily a decade for us to train one neurosurgeon. And in a world that's changing this quickly, we have to ask ourselves, how are we going to be able to keep up with all this? The paper that Key Park, one of the papers that Mike Dewan looked at, was a survey of neurosurgeons asking how many surgeries per year they were comfortable doing. And it's about 225, 250 cases per year. So whereas a lot of general surgery can be a 30 or 40-minute procedure, 1 hour procedure, neurosurgery cases can take anywhere from 3 to 12 hours. And so if you do a couple of cases per day, then you've had a busy day. So in the millennium, the World Health Organization gave us their 8 Millennium Development Goals. And this was, if you would, a report card of where our world stood in the year 2000. And at that time, one of their major initiatives was to eradicate extreme poverty and hunger, defined by living on less than $1.50 US per day. And what we saw was that with globalization over the first 2 decades of our new millennium, that extreme poverty has dropped quite rapidly to the point that today, most of the developed continents have less than 5% people who are living in extreme poverty. They're still in Southeast Asia and in Sub-Saharan Africa, there are pockets where it's still significant, but with globalization, we've seen a rapid decline in this, just like we've seen a rapid decline in childhood mortality. So in 2015, the World Health Organization replaced the Millennial Development Goals with these Sustainable Development Goals that are more long focused. And the number 3 is good health and well-being. It relates to healthcare and a call for universal healthcare for everyone in our world. So if you look at the SDG 3.2 is by 2030 end preventable deaths in newborns and children under the age of 5. I've just shown you that we've made strong headway there in the last 20 years. We look at 3.6, as Key Park mentioned, to half the number of global deaths and injuries from road traffic accidents in our world. And I'll talk a little bit more about that in just a moment. Then achieving universal healthcare coverage, including financial risk protection, making healthcare affordable for people who don't necessarily have a lot of wealth. And then down here, SDG 3.C is substantially increase health financing for the recruitment, development, and training and retention of a healthcare workforce. And we'll talk a little bit about where we stand with our healthcare workforce as well. So the other thing that came about in 2015 was a Lancet Commission report on where we stand with access to surgery in our world. So Jim Kim was president of the World Bank at that time, and he was an infectious disease doctor. And you can imagine how unusual it would be to have a physician in charge of the World Bank, but he was an infectious disease doctor, and prior to his tenure, most of the healthcare resources, most of the healthcare dollars in our world went to treating things like tuberculosis, malaria, HIV, AIDS, with the thought that investing in surgery was just too expensive, that it was unaffordable for most countries. And so Dr. Kim asked the Lancet Commission to study this, and what they found was shocking. At that time, there were 7.5 billion people in the world. Of those, 5 billion people have no access to safe, affordable surgical and anesthetic care when needed. And in low and middle income countries, 9 out of 10 people had no access to basic life-saving disability averting care. 143 million additional surgical procedures were needed in developing countries each year just to save lives and to prevent disability. And when we look at all of the money that was being poured into HIV, AIDS, TB, and malaria combined, accidents and injuries make up 3 times the number of individuals afflicted per year, 3 times. And the leading cause of death, as Key mentioned, is a head injury, a neurosurgical disease. So when you look at the burden of surgical conditions, it's estimated that about easily a third of the conditions are unmet. And if you look at this pie chart, think about it. If you're in a developing country and you don't have access to surgery, if you get appendicitis, you get cholecystitis, you get diverticulitis, there's a good chance you're going to die. If you break a femur as a 20-year-old falling off your motor scooter and you don't have somebody to knit that femur properly, you may survive it. You may lay at home for 6 or 8 weeks until it knits. But if you can't walk well, you can't work, you can't live independently, your life is forever affected. And it's estimated that in terms of obstetrical emergencies, 500,000 women per year die in our world. And when they die of obstetrical emergencies, usually their baby dies with them. So investing in surgical services in low and middle income countries is affordable. It saves lives. It decreases disability. It's estimated at a target of 5,000 operations per 100,000 people that we need 2.2 million more surgeons, anesthetists, and obstetricians. So if you're interested in neurosurgery, you're making a good career choice. There will be plenty of business. To meet the unmet need, it's estimated we would be about $420 billion. The cost of not making that happen is on the order of $12.3 trillion, and these are in 2015 dollars. So 33 million people face catastrophic healthcare expenditures as well. And you can imagine if you're working hard trying to take care of your family and you make $500 a year, if someone in your family has to have an operation that costs a couple of $1,000s, to be able to pay for it, you may have to sell your family home. You may have to go into bankruptcy. It can be financially catastrophic. And there are times where people choose not to pursue healthcare just because of the affordability of it. We'll talk more about that later. But the upshot is that access to surgery should be an indispensable part of global healthcare. So we currently have just under 50,000 neurosurgeons in our world, and you can see the breakdown in terms of where they are. In North America, we have now about 5,800. India has about 3,500. Not nearly that many in Africa, but we've made a lot of progress in terms of training and increasing the capacity for neurosurgeons in sub-Saharan Africa. But we still need an estimated 22,000 neurosurgeons to be trained, which is 2.5 times the rate that we're currently training neurosurgeons. So when we look at neurosurgical disease worldwide, the causes of death worldwide, for children, the #1 cause of death is accidents and injuries. For adults, the #1 cause is accidents and injuries. And as we said, head injury is #1. So it's estimated that 69 million cases of traumatic brain injury occur in a year. And 80% of those are mild enough that with time and with basic support from the family, these people will get over it. Some of them may not be the same afterwards, but they survive it without requiring surgery. But when you look at severe head injuries, it's over 5.5 million per year. 9% of the world's deaths are related to traumatic brain injury, and it's estimated that 14,000 people in our world die per day from traumatic brain injury. So the global unmet need for neurosurgery related to traumatic brain injury exceeds 2 million cases per year. Imagine the amount of time that neurosurgeons around the world devote to this. Hence the World Health Organization's recommendation that we try to do something about traumatic brain injuries and traumatic deaths to reduce the incidence. And if we look at this paper published in the New England Journal of Medicine last May, over the last 20 years in North America, we have been successful in cutting the deaths from traumatic brain injury by 50%, with better passive restraint systems in our cars, better highways. And our highways, if you fall asleep at the wheel and you start to veer off of the road is perforated so that your tires make noise and wake you up. You may have bumpers in the median that make noise if you start to cross the median. Unfortunately, in our world, in the last 2 years, the number of deaths from firearms has shot up dramatically. So now in North America, the number one cause of death for children is from a gunshot wound. And this is also paralleled, if you look at this, by deaths from drug overdoses and poisoning. So we're talking about social illness here, and it's something that we have to struggle with. But we have at least been able to demonstrate that in developed countries, we can successfully diminish the cause of death from traumatic brain injury by 50%. And that is one of the Millennium Goals. So if you look here, this is a cell phone video I took in India, and you can see bad roads, bad vehicles, bad drivers. It's no wonder that you've got a lot of head injuries and a lot of traumatic injuries, but money and global coalitions such as you see here with neurotraumatologists from around the world coming together. This group just has a grant from the UK of £32 million to study ways in which we can reduce traumatic brain injury and deaths from trauma worldwide. So when we look at the number 2 cause of death in children, the number 2 cause is cancer. And historically, the number 1 cause of cancer in children has been leukemia. But in the last 2 decades, again, with better chemotherapy, better diagnostics, better understandings of the molecular underpinnings of cancer, nowadays 85 to 90% of children with leukemia can be cured with standard care if they can be diagnosed. So with that happening now, the number 2 cause of childhood cancer is a brain tumor, and it has become the number 1 cause of cancer-related mortality in children. And here's a picture of a newborn with this huge tumor that was biopsied and found to be a glioblastoma. And the local neurosurgeons recommended that they go home on palliative care. They said, it's a glioblastoma, it's incurable, your child's going to die. Not knowing, as pediatric neurosurgeons would know, that nowadays children with hemispherical glioblastomas that are congenital have about a 90% cure rate. And so we operated on this child, took this out, gave her some chemotherapy. She's now almost 3 years old and doing quite well, other than a hemiparesis. But the point is, childhood cancer is something to be reckoned with. So if you look at this pie chart of childhood cancers, the cranberry are the blood-borne cancers, blue is lymphomas, and then purple is this nervous system cancers, and they make up about 20% of the cancers worldwide at the moment. So at the moment, in developed countries such as ours, 80% of children who are diagnosed with cancer will survive. In low and middle income countries, that survival is 20%. It's one of the largest healthcare disparities in our world, the difference in diagnosis and management of those children. And we look at this paper by our partners at St. Jude, you can see that worldwide, 43% of children who have cancer will go undiagnosed. And if you think about it, if you're a teenager in a remote area in Indonesia or sub-Saharan Africa, and you start losing weight, you start running fevers at night, you lose your appetite, you stay in bed and want to sleep all the time, the first thing people are going to think about is treating for TB or malaria. They're not going to stop to think that this child may have Burkitt's lymphoma. And oftentimes these children may die without ever being diagnosed. When you look at 5-year survivals in the developed world versus the undeveloped world, there's a log difference in the survival between what you see in high-income countries and elsewhere. that's something we need to fix. So St. Jude started in the 1960s, and they made their first breakthrough in the 1960s with a MOP regimen for leukemia in children. But it was in 2015 that they recognized the need to take care of children around the world and not just children in North America. And so they started the Global Pediatric Medicine Division with a 5-year plan to become more invested in children around the world, with this St. Jude global vision that every child diagnosed with cancer or blood disorder have access to quality care. And with that, in 2017, they made an appeal to the World Health Assembly, which is the actionable legislative assembly of the World Health Organization, and asked if they could collaborate with them to have a more global interest in taking care of children with cancer. So with that, they made a commitment of $200 million to provide chemotherapy for children in developing countries. And with that, they had a resolution passed for the GICC, or Global Initiative in Childhood Cancer. And following those meetings, the World Health Organization became invested in setting a bold target of trying to double the cure rate for children with cancer by the year 2030, which, if you recognize that about 1,000 children per day, 400,000 per year diagnosed with cancer currently, that would save over 1 million lives if we can make that goal. So they started out with 6 index cancers that are highly curable, proven therapies for treating them. They're prevalent in all countries, and they recommend about 50 to 60% of childhood cancers. And low-grade glioma is the one that impacts neurosurgery more than the others. So if you look at childhood brain tumors, the pie chart is relatively diffuse, but low-grade gliomas supratentorially, low-grade gliomas in the cerebellum make up about 35% of the total pie chart. They're the most common brain tumor in childhood. And the startling statistic is that the 5-year survival of a child with a brain tumor is not determined by the biology of their tumor, but by the country in which they choose to receive their care. Scary thought. So this is a study that was published. Jeff Wissoff was the first author, and we were heavily invested, but it's probably the largest brain tumor study ever conducted. Over 700 children enrolled who had various low-grade gliomas operated on in the late 1990s and then followed over the next decade. No chemotherapy, no radiation, just surgery alone, and followed. And what we recognized was that despite the subtypes of low-grade gliomas, 96% of these children were still alive 8 years after diagnosis, and 78% of them, almost 80% of them, had no evidence of progression. And then one of the startling findings of this study was that even in children who had small amounts of residual tumor, that residual didn't change in 50% of the kids over the next decade. We've seen similar improvements in survival for medulloblastoma and ependymoma over the decades with newer and better technologies, and an improvement in the side effects from our treatments in these children as well. So when we look at the GICC and our goals, it involves increasing capacity of the various countries to provide quality services for children with cancer, and prioritizing childhood cancer diagnosis and care, not just in high-income countries, but nationally, regionally, and globally around the world. And this can be done through working with countries to set up cancer registries when they don't exist, to provide funding for families who need it for referral to cancer centers where they can get cutting-edge technology, and working together for global frameworks. And I'll get to some more of this in a moment, to where we can work together to provide evidence-based standards across the world. So Our cure-all cancer children's cancer initiative involves 4 pillars of action with 3 enablers. One is to help develop centers of excellence in countries around the world. So you don't need every children's hospital in the world or every hospital in the world to be excellent in cancer care. But if you have one in a large city or in a country, and you can refer children to that, you can concentrate resources and have a means to have a cutting edge cancer care center for the children. Then providing healthcare funding, either through charitable support, government, ministers of health support, et cetera, so that families don't have to face bankruptcy or make decisions between whether to let their child die or have their family lose their home is important. Regimens for management, so published guidelines that everyone can access, and then long-term monitoring so that people can track and trend their results and see where there is room for improvement in their care. So advocacy, leveraged financing, and linked policies and governments working with ministers of health in these countries to improve the availability of cancer care. So you can see since 2015, St. Jude has developed alliances with a number of hospitals in developing countries. Nowadays, we're up to 160 institutions in over 60 countries, working with these partners to improve diagnosis and care for children with cancer. So one of the things we know about cancer is that it takes a team. It's not something one person can take care of. So we need not only good neurosurgery to take care of brain tumors, but we need good pediatric oncology. We need radiation oncology. We need neurologists who help manage their seizures. We need good rehab so we can get them back on their feet after we put them down. And we need multidisciplinary teams that can communicate on a regular basis. It's not uncommon for us to see a child with a brain tumor taken care of, where a neurosurgeon takes the tumor out, discharges them, and says, go make an appointment with an oncologist, and the family never does that, or it may be 3 to 6 months before they get in to see the oncologist, and by then the tumor's grown back or metastasized. So having a cohesive team where they have regular tumor boards that talk to one another and make plans for these children is incredibly important. The other thing that we're seeing is a big change from the subjectivity of what a pathologist sees looking through a microscope versus gene chip arrays and the objectivity of methylation arrays, gene chip arrays, having the objective findings of the DNA abnormalities that cause cancer in these children. And so around the world, if you've got a pathologist but not a neuropathologist, or you have a neuropathologist that doesn't do kids too much, you may not be able to rely on what they tell you the diagnosis is based on looking through a microscope. Whereas if you've got methylation arrays that will spit out these genetic abnormalities, this profile fits this cancer, it's much less likely that people will be treating patients for the wrong diagnosis in other countries. Another problem that is large in developing countries is abandonment of treatment. And we talked about the fact that if you don't make a lot of money, that you may have to look at bankruptcy, but there are a number of reasons why 10 to 15% of patients diagnosed with cancer may go home and die without finishing treatment for their cancer. It's not that their parents don't want them to, but there are a number of reasons, maybe cultural reasons. It may be that it's a long distance to get to the hospital for your chemotherapy and traveling back and forth. If you are a mother in northern Nigeria and you've got 7 children, one of whom is sick, who's going to take care of the other sick kids while you take that child to the doctor for their chemotherapy and spend a week in the hospital with them? So if you look at abandonment rates in high-income countries versus low-income countries, you can see a huge disparity again, related to the availability of resources to support a family who has a child with cancer. So this is a paper that we just published within the last couple of months, and this is surgery and radiation therapy for children with ependymomas of the posterior fossa less than age 3, 25-year experience. And this is a remarkable paper for two reasons. One is that we were able to follow these kids for 25 years. The other is that two of the authors are children who had posterior fossa ependymomas that I operated on over a decade ago. And they put this paper together working at St. Jude as summer medical students, and both of them intend to become pediatric oncologists when they grow up. But at a median follow-up of 18.4 years, 82% had a gross total resection. If their cancer recurred, typically it recurred within the first 2 years. And you can see the histopathology breakdown here. But at 10 years, we had almost 60% event-free survival and 72% progression-free survival. Of those who died, 24 died of recurrent cancer, 6 died from treatment-induced secondary high-grade neoplasms, 2 died of radiation necrosis, 1 from a shunt malfunction, 1 from anaphylaxis. But of these 101 children followed over 25 years, we had 1 patient lost to follow-up in that length of time. And when we look at how these kids are doing, 98% of them have a high school diploma, 89% are either in school or working, 70% sought higher education, 64% have a driver's license, and a third of them are living independently and taking care of themselves. So contrast that to this paper that was just submitted for publication on 60 patients in Lima, Peru, treated for medulloblastoma. And we look at the kids who finished therapy, and their results there are just as good as the results we have at St. Jude. Over 80% of the kids were long-term survivors. But when you look at the kids who abandoned treatment, got lost to follow-up, their survival rate was 10%. And the unfortunate thing is that only 23 out of 60 completed therapy. And what they found was at this children's hospital in Lima, if the families lived in the city and all they had to do is go across town to get their therapy, they had a high likelihood of completing therapy. But if they lived in an adjacent town and they had to rely on someone to bring them to the hospital, there was a high likelihood that they were going to give up on treatment and their child was going to die. So this is Daniel Moriera. He's in charge of our St. Jude Global Academy, and he's done several things over the last few years to make cancer care available for people around the world. So if you're an oncologist on the other side of the world, and you take care of the occasional child and you're not comfortable taking care of childhood leukemia or a child with a brain tumor, Cure for Kids is an open access, online, accessible way that people can log on, and they have e-classrooms where they can do training. They have many courses on different cancers. We have every week we have tumor boards from various parts of the world where oncologists, neurosurgeons will present cases to us, and we'll talk about how we would work them up, how we would care for them, and what they need to get through their cancers. Daniel also has training seminars on topics such as neurocritical care, infectious diseases, leadership, neuro-oncology, where we'll fly people from around the world into St. Jude, and they'll spend a week going through intensive course training and then fly back home. St. Jude pays for the travel. And then we've got clinical training programs where we can work with people in their home, these global scholars, and it's a 2-year curriculum where they can do online work from home. We have regular meetings with them by Zoom every couple of weeks to go over tumor case management. We also have an online library they can access where they can pick the cancer, pick the tumor type, and see how we would work it up, stage it, treat it, what the complications of treatment are, and to increase capacity in developing countries. Then other partners, Nikhil Bhakta runs our St. Jude Clears registry. This is an online downloadable cancer registry that if your hospital doesn't have a cancer registry, your country doesn't have a cancer registry, they can download this cancer registry and use it. And St. Jude will even provide people to help with data entry and maintenance of the registry so that people can track and trend the incidence of cancer at their institution. The ARIA guide is a comprehensive guide that Nikhil's put together on different types of childhood cancers, leukemias, lymphomas, neural cancers, how to make the diagnosis, what the workup should be, what the treatment should be, what the side effects of the treatment are, and how to treat the side effects. And this has been very good. Paola Friedreich also has developed Profiles, which is a detailed online questionnaire that hospitals can fill out so that we can see what their strengths and weaknesses are and can provide boots on the ground people to help them with areas of weakness. And then St. Jude Global Packages can be order sets. One of them was called the Golden Hour. So if a child is receiving chemotherapy and they come in with a fever, getting them started on antibiotics, getting blood cultures drawn within 1 hour of presentation has a high success rate in keeping them from dying of neutropenic sepsis. And then Kath Lamb works with ministers of health and government officials to look at ways to provide for children with cancer and improve cancer care at the local level. So getting back to global neurosurgery, as I said, the average neurosurgeon comfortably performs about 225 cases a year. When we look at what neurosurgeons do worldwide, brain trauma, number one, traumatic brain injury, strokes, tumor, hydrocephalus, and spina bifida. And it's estimated that there's a 5 million case deficit per year, 22 million patients with neurologic disorders that may not necessarily need surgery, but would benefit from neurosurgical consultation. And so when we look at it, we can recognize that the majority are going to practice in high-income settings, urban settings, because that's where the hospitals are that have the neurosurgical equipment, have the resources to support a neurosurgeon. Worldwide, general neurosurgeons will report that a third of their practice is pediatric neurosurgery, but we do know that dedicated fellowship-trained pediatric neurosurgeons will do a better job at getting all the tumor out, taking care of the kids than a general neurosurgeon will. So just to digress a minute, talking about advocacy, it's been 30 years, 3 decades since this study came out from the Medical Research Council of the UK with class 1 evidence showing that periconceptual folic acid supplementation can reduce the incidence of neural tube defects like this spina bifida child has by 72%. Periconceptual folic acid. We know that if we give it as supplements, it doesn't work because 50% of pregnancies are unplanned, and most women are 6 weeks into their pregnancy where neural tube defects have already happened before they even know they're pregnant. So supplementation of the general diet is what we know works best. And in the United States, we implemented folic acid supplementation of wheat and cereal back in the 90s, and spina bifida is a dying disease in our country, whereas my practice used to see 35 or 40 spina bifida babies a year back in the 90s. We may see 8 or 10 nowadays. But it's interesting that despite publishing that paper 30 years ago, it was only in 2021 that the UK decided to adopt global fortification of flour to prevent neural tube defects in their own country. And if you look worldwide, this is a paper from Ethiopia, which is a hotspot, but they have over 10,000 spina bifida babies born per year in a country who has somewhere between 60 and 100 neurosurgeons for 200 million people. And you can see here what the influence of that would be if they adopted global fortification of folic acid to reduce spina bifida. Talking with a neurosurgeon in Addis, he told me that his group runs 2 ORs every Saturday and every Sunday, and they will close between 10 and 20 myelomeningocele babies each day, every weekend, trying to keep up with this burden. And so you can imagine the difference that folic acid fortification would make. So this group, GAPSB, Global Alliance for Prevention of Spina Bifida that's folic acid sensitive, was started back in 2018 by Jeff Blount and Gail Rousseau as a global effort to promote global fortification. We went to the World Health Assembly last year in Geneva, and you can see us here proposing a resolution. And then this was a side event that we held on spina bifida. And you can see here, I'm showing Leah Tedeschi, who's a gynecologist from Ethiopia and is their Minister of Health, a box of fortified salt with folic acid in it that you can buy on Amazon online. Anybody can get it. Being a gynecologist, she's seen tons of kids with spina bifida. And so she went home with her entourage and implemented global fortification, not only of carbohydrates, but also of cooking oil in Ethiopia. And fortunately, the folic acid is heat stable, so cooking oil should work for people who may have dietary preferences. But with this, we would expect that within the next couple of years with global fortification, that would allow as many as 8,000 babies per year to be born as normal children instead of children with spina bifida. So in closing, I'll just state that we need to increase our neurosurgical capacity by not only training neurosurgeons, but training the trainers, training people from low and middle income countries who can set up training programs within their country, and in 5 to 10 years, be training their own neurosurgeons who can increase the capacity within their local setting. We need advocacy for safer roads, safer cars, safer transportation, and we know we can cut the incidence of traumatic brain injury deaths by 50% if we can do that. Advocacy for multidisciplinary centers of excellence in neuro-oncology can reduce childhood cancer-related deaths, and advocacy for universal fortification for folic acid to prevent spina bifida can dramatically reduce the incidence of spina bifida worldwide, which currently is about 250,000 cases per year. So if we could get this through the World Health Assembly, that would allow 200,000 children to be born as normal children per year. So we're journeying to Geneva in May, and our resolution is scheduled to be voted on. We have backing from 40 countries so far, and a number of ministers of health around the world are eager to implement micronutrient fortification of diets in their own countries to try to prevent some of these congenital diseases. So I'll stop there and make time for questions. And thank you for having me.
Thank you very much, Dr. Boop. I apologize. I was moving platforms. So hopefully there's not too much background noise. I have a question, but I'll wait until it's a bit more quiet. So if any members here, I think Mohammed has a question too.
Mohammed's got two hands up.
Thank you so much, Dr. Boop. That was a great session. I learned a lot from both your talk and Dr. Park's talk. So I have a question regarding increasing the capacity of the neurosurgery in general. So as you mentioned, for example, we don't need to have the center for treating the cancer in every single city, but for neurotrauma is more time sensitive, so we might need to have like more centers. So, and at the same time, as you mentioned, it takes like a decade to train a full neurosurgeon. Do you think a solution might be to have like a neurosurgeons which are like subspecialized, or maybe train only for the neurotrauma and then have them trained for the shorter amount of time and have them like in more centers, and then have like full neurosurgeons for like treating cancers in like a less number of the centers?
Yeah, that's an excellent question. And there are different scenarios for that around the world. So for example, in sub-Saharan Africa, neurosurgical training is 5 years, a couple of years of general surgery, and then neurosurgical training beyond that. If you look at Vietnam, they have some programs that will train a basic neurosurgeon in 3 years, and others, if you want to do complex aneurysms, brain tumors, and stuff like that, you may do 5 years of training. But just to go out and take care of neurotrauma, take care of broken necks and backs, you could do that in 3 years, no question. So there are ways to do that. And if you look at neurosurgery around the world, in many places, neurosurgeons limit their work to the cranium, intracranial surgery. So spine is done by orthopedics and other people in many places, although that's changing. But as you know, in North America, 70% of what a neurosurgeon does is spine, and that's not the case in most of the rest of the world. So there are different solutions for that.
Awesome. Thank you so much.
Mm-hmm.
I'll ask my question right away. So, Dr. Boop, you mentioned that the rate of fatalities, I believe, was 80% low middle income countries versus 20%, if I'm not mistaken. I'm wondering about the surgical treatment of the patients that do receive surgery in low middle income countries. What is usually the survival rates of those patients? Are there any data available about that as well?
There is data from specific centers, and it's quite variable depending on a number of factors. Keep in mind that in children, many of them will present quite late, quite ill. Half of them are going to present with hydrocephalus. And if you are a really busy neurosurgeon and you don't have much time on your OR schedule to spend half a day taking a tumor out, you may put a shunt in that child and send them home with plans to bring them back in a couple of weeks when you have time to get them on your elective schedule. In many places, the kids' symptoms are all better after the shunt and the family goes home and doesn't come back. So unless an institution or a group is tracking and trending their outcomes, a lot of that's unknown. And keep in mind that for most of the world, only about 40% of children who have cancer get diagnosed. Many of them die. So when I say there's 400,000 children with cancer diagnosed every year, there's probably an equal number who die without ever being diagnosed. And over the next decade or two, with increasing globalization, as that diagnosis gets to be made, we're going to see a lot more kids with cancer that are going to need care.
Excellent points. Just to clarify, so based on what you're saying about shunts, so there's no data available like shunt infection revisions in a lot of these cases because we just don't know what happens to them?
There are.
Okay, I see.
But so in much of the world, if you've got a patient who needs a shunt, the doctor gives the family a prescription and the family goes to the pharmacy and buys a shunt and brings it back to the hospital for the doctor to put in. And if they can't afford a shunt, the cost of it, then they may have to go to their community and fundraise or to their church and fundraise. It can be very complicated. But in much of the world, if you can't pay for an operation, you don't get an operation. And that's one of the tragedies of it. So, Arian, question, you've got your hand up.
Yes. Yes. Good evening, Dr. Poop. I'm so happy. I ran into the advertising from someone who's a very active last year medical student here in Canada. Myself, I'm originally from Albania. I'm a foreign graduate who trying to pursue training here in either Canada or US. But I wanted to thank you very much for sharing the data, the general information, but as well the sites and the resources that you are offering to maybe trainees from low-income countries. You mentioned that there is the opportunity for physicians like my country that can come and spend some time with your colleagues at St. Jude and I find it outstanding. I cannot tell you in how many cases during my training back home, I remember myself and senior colleagues, we had to give up on treating a case. In several, not just one, in several occasions, we had to ask patients and family to buy. I'm not saying to pay for their treatment. I've never done that. Maybe you wouldn't believe me, but to buy medications, instrumentations. I wanted to attend the meeting on the scope of global neurosurgery, but I'm so happy that there were more information into that than just global neurosurgery. And I'll try my best to share the resources that you shared with us with some of my pediatric oncologists back home and neurosurgeons back home, for them to reach out to your colleagues and St. Jude, hopefully to build a bridge of any way we can help our patients back home. So thank you so very much for being here with us tonight. Thank you. And as well, I need to thank the organizers, Saman, always very active, and Mohammed, who's about to start his residency this year. So best of luck and thank you. And Davin, thank you. Merci beaucoup. Bonne chance à toi aussi.
You're very kind.
Thank you.
Thank you for the opportunity to speak.
Thank you so much for being here with us. Really outstanding double speakers, yourself and Dr. Park, a true inspiration. And we're really glad that we could host you and hope that we can stay in touch with your campsite. So I think Aaron also has a second question, or is it the same hand from the previous one? No, same. Okay, perfect. Any other questions? Anyone else know? Perfect. Thank you again, Dr. Boop. It has been an honor, and we will make the recording available and we'll send it to you as well once it's made available.
Oh, thank you. I would appreciate that.
Thank you very much again.
Dr.
so
Have a
much,
great
Dr.
afternoon,
Yeah.
everyone.
Have a good day.
Dr. Boop.
Bye-bye.
Have a good day.
Thanks,
Thank you.
everyone.
Goodbye, everyone.
Bye.